And hello again. As you were just hearing from me in the previous session, this is our final content session of the day, which is a panel discussion on reducing the burden on staff. So we're going to be talking about things like improving communication and collaboration with colleagues, changing cultures and developing leadership skills, and using technology effectively. So all sorts of ways of basically helping staff do their job. So I'm delighted to welcome our panel. So we've got Victoria Cooper, Head of Nursing at the Emergency Department at St George's University Hospital NHS Foundation Trust, Maria Swift, Discharge Manager at University Hospital Sussex NHS Foundation Trust, Leslie Jones, Head of Nursing for Professional Standards and Digitalisation at Hywel Dda University Health Board, and Fran Beadle, National Clinical Informatics Lead Nurse at Digital Health and Care Wales, who we heard from at the beginning of today. So welcome to the panel. Each of them is now going to give a short introduction on their experience and thoughts on the topic, and then we'll get into some questions. So basically, please line those questions up, audience, in the usual way as we have done throughout the event. Send them in via swap card, and I will put them to the panel. Right, so I was thinking we would probably go in running order. So in that case, that means we start with Victoria, please, if you're happy to go first.
Absolutely. Thank you. And thank you for inviting me to be part of the panel. As everybody else has had over the last year, has come with many, many challenges and increasing burdens on staff and many changes. And in the emergency department, it was increasingly difficult to provide the space that we needed for the amount of patients that were coming in and to maintain patient safety for infection control guidance. And plus try and keep our staff safe, because staff areas are also not built with a lot of space to socially distance. So there are many things, many guidance changes as well from Public Health England. In the beginning, we were all learning. And the way that we helped reduce the burden on staff was to involve the staff in the changes. So very often we would need to make those changes very quickly, and the guidance would change very quickly. So you may remember right back in the beginning, there were red and green pathways that would feed into patient flow in the hospital. And that's the one thing that the emergency department is the front door of the hospital, but we feed into the rest of the hospital. So what happens in the emergency department absolutely impacts on the admissions within the hospital and then the discharges outside of the hospital. So ED is not an entity on its own. So we needed to have the staff on board and to reduce the burden, because they're still doing the day job in very, very difficult circumstances with increasing acuity and increasing challenges every day. So we introduced huddles, and we had the huddles first thing in the morning. There was representation from all of the staff groups and the senior team, and we all took away actions to action the up-to-date guidance or the changes for that day, and we asked for everyone's input as well. And that was key in helping share the load, but also to hear of the challenges in real time. And I think that was one of the biggest wins, I would say, from wave one that we took into wave two, was actually listening to the staff and acting real time. So being very proactive and very dynamic in the changes that we needed to make with patient pathways. The other thing that we did around staff health and wellbeing that was really important was supporting staff with just ordinary things. So we were very fortunate that we got a lot of donations of food from the community, and that made a real difference. And it became apparent that if we could look after the basic needs for the staff coming in, then that was a big win for health and wellbeing. We introduced weekly staff support sessions. We made sure the team was available, not only to talk about the challenges at work, but the challenges people were having outside, because we have to remember we had to live with COVID outside of work life as well. And that came with its own challenges. There's a lot of, it's a young and very flexible and movable workforce in London. So lots of people we found lived on their own or lived in shared houses with other nurses and doctors, and that came with their own challenges of not being able to escape COVID and have their normal networks around. So we created that in the emergency department to help support them.
Great, thank you very much, Victoria. So next up, can we have Maria?
Hello everyone, I'm Maria and I'm the discharge manager at Worthing Hospital. Obviously, in response to the outbreak of COVID-19 and in line with our national guidance last March, we were tasked to focus and drastically reduce our medically ready for discharge patients, with the aim really of having no MRD patients within our acute and community beds, as every hospital was. At the time, this felt like a huge ask, as usually we would have approximately 180 patients medically ready for discharge across both our sites at that time, which were Worthing Hospital and St Richard's Hospital in Chichester. Within a few weeks of the guidance and the requirements being launched, we set up an integrated discharge team, which was multi-agency and multi-professional, with members such as our own Director of Operations for Resilience and Flow, myself, urgent care leads from CCG, managers from CHC, social services and Sussex Community NHS Foundation Trust. As an integrated discharge team, we developed a discharge hub, providing a single point of access based on our discharge to assess model. In the early phase of March last year, this discharge hub was undertaken by the CCG to work in that hub, but it moved swiftly to the My Discharge team and discharge coordinators to manage it from April 2019. And we are all of a sudden plunged into an 8 till 8 service 7 days a week when we were doing 9 till 5 Monday to Friday beforehand. As well as having to train my own discharge coordinators to working with the discharge hub, we obviously needed to train our wards, and the discharge coordinators did this because what we wanted to do was them to develop a unified referral form and have that completed and accurately completed and then sent to the discharge hub. So training was given to our wards by the discharge coordinators to explain what the patients required. We explained what all the pathways were, such as pathway zero for patients on the ward, that they would be expected to be discharged by the actual ward staff, because they would be seen as simple restarts when a patient can obviously return back to their own home with their previous care package or back to their own care home, wherever they come from, where the needs hadn't changed. For pathway 1 to 3, as I said, the ward staff were made aware that once a patient was confirmed as being medically optimised and for discharge and requiring support within the community, the wards would need to carry out completing a unified referral form. And as I say, this was devised by many members and multi-organisations within the integrated discharge team. So this referral would be completed. The hub would then manage these referrals. So what we instructed the wards to do once they completed the actual referral was then to send it to our discharge hub, and we'd set up emails so that they could scan it and send it to us relatively easy. And these would be for the pathways 1, 2 and 3. Within the hub, then, we would quality check all the referrals. So every single referral that comes from the ward, we quality check. And if there's missing information or we feel that they've chosen an inaccurate pathway for that patient, we then get back in contact with the ward and we discuss what they need to improve upon. Or if it's very minimal, then we as discharge coordinators will do it ourselves within the discharge hub. This was undertaken against the principle of trusted assessment as well, before sending the actual referrals to the placement and sourcement team or to our Sussex Community Trust partners for CRB beds. The placement and sourcement team comprises of a multi-agency group as well, which was West Sussex County Council and CHC staff. That was a virtual team hosted by our West Sussex County Council partners, and they had oversight of all available provision and capacity, and would identify the best match for our patients, and then obviously come back to us to tell us where who the care provider would be or who the placement would be. Once the patient is in their own home or placement or replacement, then they're reviewed within 1 to 2 weeks after discharge. So obviously they're assessed almost immediately. If we put on the referral form, they need same day assessment, otherwise reviewed within 1 to 2 days. But their actual review on where they're going to go next is within the next 1 to 2 weeks. And this is a huge role that's been undertaken by West Sussex County Council again. So assessing people once they're discharged from hospital to move on from interim arrangements. However, this is really key to supporting the flow for us, because obviously if they don't assess in a timely manner, then we would get a blockage because we'd be waiting to discharge our patients and they wouldn't be able to move. So it really needs to work very well, very organised. And I have to say, West Sussex County Council pulled out all the stops to work with us. In addition, in order to ensure that we can meet the guidance and targets for our medically ready for discharge patients, we also carried out 2 touchpoint calls a day, and sometimes 3 if we were really under huge pressures, which, as you can imagine, last year we definitely were. While we carried out the touchpoint calls, they were obviously to provide us with opportunities to escalate any concerns with individual plans or to seek an alternative viable resolution for with our community partners and adult services, etc. And we focused on our community teams pulling out our patients. Obviously, we worked really well, collaboratively, very collaboratively. This has improved our relationships, and it's improved our team working. It's certainly improved our trust and respect to each other. And through being able to be like this and being open and honest, we had a no blame culture. So if there was an issue, we would just discuss it on the touchpoint call and go forward. So I think basically, our trust between each other, all the organisations, has really removed the blame culture, and which we were all really proud of. And obviously, to continue with this, we obviously needed our IT department as well, who produced what's called a medically ready for discharge list for us, which is pulled off our discharge tracker. I haven't got to explain that completely, but basically what it is, the discharge team input into that discharge tracker that anyone who's medically ready for discharge, they are on that list. And so when the medically ready for discharge list is pulled out, it's taken our information from that tracker. That is then shared with all organisations, because we know we're not quite up there with sharing all our IT systems. What we certainly could do is send lists to them and then communicate within our touchpoint call, which was absolutely brilliant. Within the touchpoint call, there was a senior discharge coordinator lead as well within the Sussex Community Foundation Trust. And basically, this gentleman chairs all the calls that come in. He then assists us with a discharge plan. He leads on assigned action, so that if no one actually picks up an action, he will say, sorry, who's going to lead this, etc. And then we make sure that we're working within timeframes to ensure that obviously the discharge is facilitated within our agreed timeframes and on the same day. He also provides a senior support if we have any major issues that we could escalate. And to capture any system risks and issues, I suppose, as well. And to make sure, what our main, for everyone, what we wanted to do was to make sure we were going to discharge our patient safely. And that was number one to us. And that's where we could really have a good, open and honest discussion. So we knew that would happen. Just sort of in summary, as a result of setting up the Discharge Hub, and working collaboratively together, we managed to, from having a medically ready discharge list, as I said, of 180 patients, we managed to reduce that by 110, which we feel that was brilliant. So we now have an average of 70 patients who are medically ready for discharge on our list each day between Worthing and St Richards. But obviously those patients drop off and get discharged, but then we get new patients on. And so it's sort of around about that figure. We also managed to reduce our long length of stay as well, which reduced from 165 a day in February to 101 for the same period in March this year. And the number of days patients spending being medically fit was averaged at 8.5 days, and that was in March 2020. And it's now, we've got that down to 2.8 days, which we feel really proud of. And as I say, it's certainly the only reason this has worked really well is that we've all worked together and been so open and honest and literally brainstormed every patient who we feel might be a little bit more complex than others, so that we can get them through our system safely and obviously in a very timely manner to support the COVID guidance. And that's it, really.
Great, thank you very much, Maria. I'd just like to say actually at this point that after those, the first two speakers there, it's just reinforced to me that despite the unprecedented and quite frankly awful challenge of the pandemic, I've just heard so many positives over the last 2 days about the way that teams have adapted and the things that they've introduced and the results they've had. So yeah, right, okay, and now Leslie, please.
Hi, yes, thank you for inviting me to speak to you today. And you're quite right, to do anything in a pandemic is difficult, but to roll out a digital record has been quite a challenge here for us. So I lead on the National Implementation Group for something called the Welsh Nursing Clinical Record, or as we call it, the WNCR, because everybody loves an acronym really. And I work in Hywel Dda UHB, where the WNCR software has been rolled out first in Wales, but it is an across Wales software system. I also went to England in 2018 and undertook a digital fellowship, which led to me doing projects for NHS Improvement England. I wrote a clinical informatics career framework. I collected and published varied clinical informatics career stories and developed a how-to guide to help organisations manage rollouts with a toolkit. We've a long way to go on the digital journey here in Wales. However, we have spent a good amount of time standardising our documentation nationally, and this has helped us get to a national rollout. Once one thing is rolled out, more will inevitably follow. What we have seen with the WNCR, and particularly with patient flow, is there is less duplication. The digital record follows the patient, and this is especially good as we started our rollout at the end of the patient's journey in a community hospital, then moved to the acute setting. This meant that areas that pull patients through the systems were already configured into WNCR and staff were proficient at it. Staff like the system as it can see patients' measurements and assessments at a glance, such as nutrition, pain, tissue viability, falls, IPC as examples. The system allows us to grow as well, and we're now investigating putting more assessments and care plans into the system. It is already being utilised widely by nurses, and they love the digital simplicity of just clicking that submit button. Our WNCR system pulls the patient demographics through from an underlying PAS system, and that this means our ward areas are already populated with patient data when the nurses log in. We have a lot to learn, and we have learnt an awful lot. So far, the things that are important are these. We needed to make sure our super users stood out. Nurses like freebies such as lanyard, pens and badges, and all of that would have been good at launch instead of implementing it later. But I think they are good things to identify our super users. The need to get site operational teams trained up in issuing access is also essential, especially for our agency staff. And training, whilst training is okay, but there's nothing apart from using the system which actually makes people understand it a lot more. So we prepared 2-minute videos, 12 in all, and these really helped because they were almost used by the staff as podcasts. And the key to the success has definitely been around the rollout, the people we have on the ground, our CNIOs and lead for informatics. And we definitely need more of these roles and a more interprofessional approach to these roles. So when I developed the career framework, unlike other careers in informatics, it tends to cross banding boundaries. And what I mean by that is you can be a senior nurse in a supportive role, or you can also be a healthcare support worker with specialist informatics knowledge. So we use these headings to structure the informatics career framework. So we had supports, specialists, influencers and strategic people, and suggesting varied courses to help them within the rollout toolkit. In the toolkit, the principles that are within there that organisations need to consider with any rollout are definitely leadership, engagement, the hardware and software, communication, training, and definitely timing. Are you going to go big bang with the rollout, or are you going to do it in a paced way? So with the WNCR, we are rapidly approaching business as usual for this rollout, but the system will continue to develop. And can you imagine if it develops in an MDT type way? How amazing would that be to have the team around the patient, both digitally and in real time? Thank you for listening.
Fantastic. Thank you very much, Leslie. And last but not least, Fran, welcome back.
Thank you. Thank you very much for giving me this opportunity to talk. And I look at flow a bit differently to everybody else around. It's not just one system, it's multiple systems. So as I said, I'm the National Clinical Informatics Lead for Nursing in Wales. But my previous role, I worked in the Middle East, implementing a procured solution. And essentially, for me, there are lots of different systems, as in we have patient administration systems, we have emergency department systems, we have critical care systems. For me, it's about flow is about looking holistically and put the patient at the heart of everything that we do. And the pandemic absolutely has helped transition people to not be so scared of digital ways of working, because it's been a requirement throughout. But flow is everybody's business. It's not just nursing's business, but actually, in order to reduce the burden of documentation on our nursing staff, we need to look at what we're collecting, where we're collecting it, and why we're collecting it. Because are we just collecting information just for the sake of it? And I think the standardisation journey that we've been on in Wales has absolutely made us look at what we're collecting. Why are we asking these questions? You know, there were questions that were totally meaningless that were being asked in nursing assessment because that it had never been thought of. I mean, one key thing that we're looking at currently is changing the way that we care plan, because care planning for nursing doesn't actually work that well. We've got to, because they have become documents that sit at the end of the bed. So how can we provide information based from our assessments, but also from our patient administration systems, but feed this information backwards and forwards? So for the clinician, the nurse, the AHP on the floor, we should be looking holistically and not just looking at separate systems, because actually this is ultimately about the patient, and the patient flows through all areas of the healthcare system, and that includes community and secondary care, tertiary care, community hospitals. We need that information to follow through. And like Leslie said, it's about growing. We need to grow the workforce, the nursing workforce, to understand and translate this for our technical colleagues, and vice versa, translate what our technical colleagues are saying to our nursing colleagues, or to the wider colleagues, to have the appropriate conversations and reduce that burden, and not just document information for the sake of it. And that, because we need to feed the beast, we need to, we need to meet audits. Actually, all of this documentation should come from the documentation that everybody does, and that's not just nursing, that would be physicians, that would be administration system. You need to look at system-wide change. It's not enough to look at one individual item. So, and in Wales, we've looked at how we can grow our digital leadership, along with ensure that we incorporate digital capabilities and actually translate that language. So we're actually in the process now. We've developed a clinical professional career pathway that goes from nursing to nursing, our AHP and healthcare support workers can engage in that process throughout. So for me, the biggest lesson to learn is about standards. You can't have the fantastic AI, the patient flow, unless you've got those standards. They've got to mean the same wherever the patient enters or is discharged from the system. That's where flow comes from.
Fantastic, really good point to end on. Thank you. Really common thread there coming through about in terms of improvement coming out of all of this on integration and getting those systems, different parts of the systems, I guess, to work together better. It seems certainly ones that probably haven't worked together for a while, if ever. And just listening there, Fran. Just coming straight back to you. Again, I've heard about various initiatives around involving technology, of course, a lot over the last few years. Do you think the key is it getting nurses or whoever the healthcare members of the healthcare team are actually directly involved in at the beginning and designing it around them, as opposed to making the mistake perhaps of trying to impose things on staff.
Absolutely. And it comes from leadership as well, nursing leadership as well as the end user, because as you know, many colleagues have said, and from the RCN digital survey and surveys that we've done ourselves in Wales, clinicians feel that IT is being done to them. Actually, it needs to be the other way around. It's got to be clinically driven, because actually without it being clinically driven and meeting within their workflows, so their daily workflows, it's seen as an added extra to document. So you're not going to get the true value out of it. So it's very much for me that it needs to be driven from the profession. It needs to be driven from the clinician, but it also needs to be driven from the patient as well. We need to make sure that the patient is involved in that, and that it's about the language we use with each groups. And actually, I think the profession, if are scared, they're scared of technology, but actually by having these positions that help support them to drive through to have the appropriate conversations with technology makes it work. Because actually, if you don't know that something's possible, you're not going to ask for it. You provide a nice piece of whiz-bang technology for a clinician, of course they're going to say that they want it, but actually what they don't know is you've got to develop it. They don't know the possible because they've never been told the possible. So yes, it's very much got to be clinically driven.
Great, thank you very much. We've got a question in, and it's one for Victoria, and it's from Amy Bromwell. And first of all, she says hi, and then she goes on to ask the interventions that you put in place for staff in the ED sound great. Was this something that you have continued throughout the various waves of the pandemic? And there's a second half, which was, what has been the feedback from staff, or what has the feedback been like from staff?
Hi, Amy. Two great questions there. Yes, we have been able to keep up the health and wellbeing, and in fact, we've made it into a work stream now. So we have dedicated team of staff within the ED that take this on as part of their role, and we have a matron leading on it. And we actually put in a bid for some HEE funding for the junior doctor health and wellbeing space, and have created a health and wellbeing room as well, which we've called our priority 1 room for staff. And it is a safe, quiet space. It's got a sofa. It's got lots of lovely things in it that aren't clinical, where people can go and decompress, which has been enormously important just for everyday ED life, never mind in the pandemic as well. But yes, we've used what we learned from wave 1, and we've continued it through our health and wellbeing work stream. So we still have staff support coming weekly, offering group sessions of support for staff that are independent from us. And we also try and tie up some fun things for the staff to do, because obviously their normal networks aren't there. So we do quizzes, and if we get any donations, we use it as raffle prizes. So yeah, we've been able to continue it. And in terms of staff feedback, I think it has been very well received. I think the difficulty, and it's interesting because I put out in my message to staff this week, that I think health and wellbeing in some ways people see as touchy-feely or a luxury. And I think what we have to recognise is that staff health and wellbeing is about staff safety and patient safety, because if staff feel okay physically and mentally, then they do a better job. If they do a good job and a better job, then that impacts on patient safety. So our people are our best and biggest asset, and we need to look after them. And that is, if that's having conversations, providing support for them, providing quiet spaces, or even just nice spaces to have a rest, then that's what we need to do.
Here, yeah, definitely agree with that. Nursing Time has been running a campaign over the last year on staff wellbeing and mental health, so it's an issue that I'm particularly interested in promoting at every level. So yes, thank you very much for that. Right, so moving on. So we've heard a lot about how things have been more dynamic, decision making particularly. And again, Victoria mentioned huddles, I think stuff. As a panel, what do you think? Should we keep that kind of approach going, or is it basically an adaptation to a pandemic, and we need to go back to the old ways, or do we need to adopt a more dynamic approach, do you think, to decision making? I'll start with Leslie. Sorry, Leslie, put you on the spot there.
Now, I think there's a lot to learn from the pandemic. I think it's brought us a lot of learning and we've got to hold on to some of the dynamic nature of that as well. We've had to learn very quickly, about doing video conferencing with patients. We've seen that completely explode in our environments, how we manage patients coming through our doors. I think we've learned a lot, and I think hanging on to that and making those informed decisions quickly, the decision process has definitely speeded up in organisations. And I think we've seen people have to make decisions on the hoof sometimes. So I think we need to hold on to some of those systems, because actually it can be quite clunky otherwise to get things through. So I think we need to hold on to some of that dynamism moving forward.
And what about you, Maria? Do you share the same view, or?
Yes, I do. And I think one of the main things for me is that it's not just being about dynamic, it's being sharing with each other and working with other organisations really closely. I think we've always been dynamic. Certainly that's how I feel with our team. But what we haven't done, we've worked in silo and we haven't worked together. So if we've got an obstacle or an issue, we email someone, we wait for the response. Sometimes that's particularly not very quick and it might not be shared that well. Whereas now we've got a problem, we don't email, we talk on the touchpoint call, we get an answer immediately, or they answer you back. So it's, to me, it's been working more dynamically, but certainly working more collaboratively as well has been a real success.
Great, thank you. And I suppose likewise, a lot of things have gone virtual, as we've mentioned. So we've had all the using the different bits of kit that we're all so familiar with now on a daily basis. I suppose a similar question, would you like to see some of that retained, or should we really be moving back to face-to-face, or is it a mixture of the two? So who shall I go to first on that one? I'll ask Fran that one first.
Yeah, I think there is a very fine balance between doing everything digitally and remotely and actually physically seeing people. I think, there are absolute times where you need to be physical and have a presence with patients. I don't think it's necessarily something that needs to be done every time, but I do believe we need to listen to what the clinicians want, but we also need to listen to what the patient wants. We have gone online for a lot of technology stuff, but also remembering, our older generation are probably not as digitally inclusive, and it's not. So it is, for me, it's a very fine balance, but we can't go back to what we were doing before, but we do need to, moving forward, like others have said, retain some of that. But actually, for me as well, there is, about investing in technology. I think COVID, obviously, there's been a lot of investment with regards to equipment and how we do it. But why was that not there before? Because flow was always an issue before that. So we need to maintain and policy needs to understand that technology needs to be invested in as well. And that is not just devices and programs, that's also about the people.
Great, thank you. Victoria, I suspect there's less, I don't know, the virtual world and emergency departments possibly, I don't know whether the crossover is there, but do you have a view on how that kind of virtual world should or could continue?
Yeah, I think in the emergency department, we don't see patients virtually, but we have virtual we have embraced technology, and we've had to. So with the 111 service has been something that has been brought in to help the emergency department. But just picking up on what Fran said, I think we need a balance, because the virtual world has allowed staff perhaps to access a lot more support, meetings, and be more involved in the department, because things happen virtually. People can log in when it's suitable for them, and we've been able to maximise on those opportunities. I think what the pandemic has given us all as a profession is we're very innovative and creative anyway, but it's given us the opportunity, the support. It's been really blown wide open to say, okay, find a solution. And you will know this, Steve, from all of your years in the Nursing Times, but nurses see the challenge and find solutions. We want to do what's best for our staff and our patients. That's what we do. So in COVID, yes, it was horrible and horrific in many ways, but it's allowed us to maximise on opportunities. It's allowed us to innovate. It's allowed us, with senior support, particularly at George's, they were really supportive of my sort of fail fast mantra. Let's try something. If it works, great. If it doesn't, let's put it to bed and move on to the next thing. And I think with the virtual world, it has allowed staff to feel more connected in some ways, but in other ways, and particularly in ED, we're a very close-knit team. We are missing our face-to-face networks, and I know that we're all looking forward to a day when we, in ED, we're very tactile, we're big huggers. So, you know, if you see an ED nurse, then you're likely to get hugged, I'm afraid. That's just the way we roll.
Fantastic. Now, obviously, all four of you are change leaders, but what's your advice or message for nurses who want to start a conversation about improvement or an initiative that they want to see in their own organisation? And I'll go to Leslie.
I would say to anybody in the profession, really, you need to be curious, keep asking a lot of questions, and ask questions of the staff above you as well as your peers as well, because you will refine that question and you will get an answer to it through using the improvement methodology. So I think don't take things at face value. So it's constantly improvement is something that is and should be there every day. We should be thinking about it with everything that we do. So I would ask questions, and if you ask questions to the right people, then you gather momentum. And once you've got momentum around a project, it's hard to let it drop, really, because you know it's the right thing to do. But you do it as a team as opposed to as an individual. None of the things we've heard of today have been done by individuals. They've all been achieved through and with teams. And I think that's teams, the real teams, as in real people, not teams, the Microsoft teams, which we all use far too much of. So we do improvement through using and working with our colleagues. So I think it's about being curious and garnering momentum is what I would say.
Maria, so what's your advice on for nurses wanting to implement change on their patch?
I think I'd support really what Leslie said, but yes, if you're really interested, you can put out the feelers, find out who else would be interested in that particular topic or whatever it is project, and get them on board as well. As Leslie says as well, you know, it's much easier to work within a team rather than on your own. So if you can get a few people's support, and then you can hopefully get someone to lead that and present it to the right people. But it's always, you know, carrying on. Don't fall at the first hurdle. Just because someone isn't interested, go to the next person, see what happens. And I think a lot of the time it is best to do it in person rather than email. Even if it's Microsoft Teams, that's better than an email sometimes, so you can share your enthusiasm.
Fantastic. Sorry, I would have come to the rest of you, but we're actually nearly out of time. So we had some good advice there. So I'll save you the last word. So thank you very much to our great panel there. So Fran, Victoria, Leslie and Maria, some really brilliant information and advice there. Absolutely loved it. So thank you very much. Right, so essentially we are now out of time. That brings us to the end of the 2021 Patient Flow Forum. So thank you to all of our speakers today, as well as our panel that you just heard from. Thank you very much to our sponsors, Galen and Gamma, for making the event possible. And thank you to you, all of our delegates, for participating and engaging and asking such great questions throughout. We hope you took away valuable insight to support you in overcoming your own patient flow challenges. And as I said just in the last session, my takeaway message, I think, is that despite the unprecedented challenges, I just heard so many positives over the last few days, and things that we can really take forward and retain, just as a result of a horrible situation that we found ourselves in. So please enjoy the rest of your days, and I hope to see you next year or at one of our events before then. So thank you and goodbye.